Okay, it is 3 p.m. We are gonna get going. Welcome to Coffee and Cases, the January edition. Happy New Year, everybody. Hope you had a lovely Christmas season and are settling in for just a few more weeks of winter. Maybe some hot holidays planned, maybe just hunkering down in the snow. Either way, we're glad you're here with us today. Just before we get started, I'm Ruth. I'm stroke nurse here in Saskatoon, and this is Dr. Brett Graham. He's one of our stroke neurologists. And I want to do a quick land acknowledgement. So while we meet on a virtual platform, I would like to acknowledge the Indigenous people of all the lands that we are on today and take a minute to acknowledge the importance of the lands which we each call home. As we gather here today, we pay our respects to the First Nations and Métis ancestors and reaffirm our relationships with one another. And just as a reminder, today during our Coffee and Cases, the cases and the topics that are presented don't have anything to do with actual patients. They're kind of made up. And if you have questions, again, like high level kind of things, we don't want to tramp on anybody's privacy. So, but this is about community and sharing and learning from each other. So if you have expertise or ideas you want to share, we invite you to do so. And certainly you're always welcome to chime in with questions and stuff and help answer questions if you have answers. Now, Brett.
Yes.
Next Monday. It is a certain day in the month of January and in the year 2026 that we should probably just get off the chest what it is.
That's true. So next Monday, January 19th, is sometimes known as Blue Monday. It's supposed to be the saddest day of the year. It's been, I think that coin was termed in 2005 by a researcher or tutor at Cardiff University in Wales. It then later came out that he was working with a travel company, so kind of like shined some maybe poor light on his research. But basically, using an equation, it was an actual equation he came up with, looking at weather conditions, right? Low light in January, debt level. We're all getting our visa bills from the Christmas season. Time since Christmas, there's a little bit of a Christmas letdown. Time since New Year's resolutions have been broken. Most of them have been broken by now. Low motivation and feeling a need to take action. All those things, you pop it in, boom. It's usually the third Monday in January. Most of the time, it's supposed to be Blue Monday. Even though the whole idea of Blue Monday has kind of been, kind of blown out of the water a little bit, there's some truth there, right? In regards to seasonal affective disorder, right, with light levels, kind of now that we're in January, getting out of it. Ideas to the idea of Monday tends to people have the lowest mood on Mondays and highest cortisol level in general, probably getting back to work. And also on the flip side, there's TGIF, right? Highest moods on Fridays and stuff like that.
Good moods on Fridays.
So yeah, so it does also, even though it's it's not a really good research question anymore, it does kind of nice to shed light on mental health, right? And things we can do to maybe make it better.
Yeah, so that's what we're going to do today. But I have some accolades, on our last Coffee and Cases letter, Ashley, our producer Ashley, introduced the Rewire and Inspire. And this is a place where we want you guys to get involved and send Ashley and us ideas about what is going on that's so great in your centers, because I think it's really important that everyone celebrate the greatness that is our province and stroke care in our province. And you guys, it is time for a little data minute. I'm going to try and share my screen. You know, I'm old and sometimes this is tricky, even though I've been sharing for literally years. Let me see if I can get this to share. We're going to take a minute for the data. Maybe. Where did my share content? I want to share. Dang it. I want to share. I'm going to share. Screen. Maybe I won't share. There we go. Still might not be able to share. I want to share screen 2.
You click on share.
Share. Are you seeing screen 2?
Mm-hmm.
Okay. Okay. Provincial data update. Okay, you guys, we are going to take a quick look at Q1, which I never know what quarters are. So it's January 1st to March 31st, and then Q2. I think this is right. Anyway, January 1st to March 31st. So this is kind of what we looked at last time. Just as a reminder where we were at, our median door to needle. So time patient comes in to the time they get TNK, remembering that time is brain, and every minute we are not treating those patients, 2 million neurons are dying. And the faster we treat, the better functional outcomes our patients have. So our provincial median was 66 minutes. We are always striving to get under that 60-minute mark. So that's kind of where we were, January to March. And then March to April, our median dropped to 62 minutes. So we're doing a little bit better. Again, target is less than 60. So you can kind of see the trends here, and how many patients we're treating around the province. It's at the very bottom. I know it's a little bit little. Melfort doing great. Our newest stroke center, you're doing awesome. 2 patients out of your 9 stroke alerts got TNK. Some places didn't treat at all. Regina, Saskatoon, again, the heavier hitters because we have lots of strokes. But big kudos again, Moose Jaw, you are blowing it out of the water. 46 minutes, that is incredible door to needle times. And I do need to take honorable mention because I know that you guys, I've told you this before, when Saskatoon hit 30 minutes, we would also kind of celebrate that. And we did. We hit 30 minutes. And so between us and Moose Jaw, we get the TNK champion.
Oh, it's disappearing.
If you put them in front of my face. TNK champion award. So way to go. You guys keep on doing the good work. Keep on aiming for less than 60 minutes. That is, that's our goal. All right, so now I'm going to stop sharing. And I'm sure I didn't see it. I'm sure you guys were all sending out those little woohoos and right-ons, especially for Moose Jaw. We love you, Moose Jaw Stroke Center of Excellence. Okay, but now without further ado, let's introduce our special guest. Kirsten. So Kirsten is coming to us all the way from Regina. She was born and raised in Regina. She completed her Bachelor of Arts degree at the University of Regina and went on to complete her PhD in clinical psychology at the University of New Brunswick. She completed her residency with Alberta Health Services in Edmonton. She is proud to work in the field of health and rehabilitation psychology, where her clinical assessment and intervention skills are applied to patients experiencing illness and injury. Since April of 2023, she's been working in the adult program at Wascana Rehab Center in Regina, supporting inpatients and outpatients who have experienced stroke, spinal cord injury, amputation, and chronic pain. Her favorite clinical topics are acceptance and sleep disorders. And today, Kirsten is going to be speaking to us about supporting psychological adjustments to stroke and what every care provider can do. So thank you so much for being here, Kirsten. I know you and Ashley did a bit of a practice run with your slides. So I'm going to kind of let you guys take it over and mute myself.
This is the real moment of truth, no matter how many times you practice setting this up. Okay. All right, there we go. So I think everyone can see my slide. Please someone tell me if you can't. I have you on 2 screens just to make sure, but thank you for having me. I'm happy to represent the very limited number of SHA clinical psychologists who work in the health and rehab space. Also on the call is my colleague from the adult program, Dr. Ada Thorsdottir, and I think Dr. Rachel Burton from the inpatient rehab program at Saskatoon City Hospital might also be on the call. So it's kind of our little contingent of rehab psychologists. My general goal for this talk was to present something of value to healthcare providers from various disciplines working in really diverse geographical locations across the province who encounter stroke survivors in various settings, ranging from primary care to acute care to rehab to secondary prevention. So we probably all know that the mental health of stroke survivors is everyone's responsibility, but we can also say that it's not expected that every provider is going to have the time, the knowledge, or the skill to conduct a thorough mental health assessment or deliver mental health intervention to stroke survivors. So today's presentation is meant to remind each of you what you can do to help support patients' adjustment to stroke in the care setting you work in. I'm going to work very hard to remember to advance my slide. So if anyone knows me, I'm quite ambitious with what I like to talk about. So here's our ambitious itinerary for today's presentation. So first, I'm going to provide some background on psychosocial adjustment to stroke. So this will include reviewing some normative emotional reactions to stroke, discussing the identity, social role, and valued activity changes that typically occur after stroke, reviewing some difficult topics that often come up with stroke survivors, talking about post-stroke emotional ability, and finally noting some of the more common clinical mental health issues that arise after stroke. Next, I'll walk you through what I see as 3 opportunities for every healthcare provider to support their patients' adjustment to stroke. So we'll talk about practical things you can be thinking about or doing when you provide stroke education. Next, we'll talk about mental health screening that every provider should be doing. And finally, we'll walk through making a mental health referral. And I'm going to do my best to sprinkle some case examples throughout the presentation. So to kick things off, we'll talk about normative psychological reactions to stroke. And I include some of the relevant characters from Inside Out because I absolutely love thinking about the feelings inside of each of us being these adorable creatures. So we know that a stroke of any severity can be life-threatening and a life-changing event. And this is why it shouldn't really be a surprise that stroke has the potential to stir up a lot of distress in the form of unpleasant thoughts and feelings. And although these internal experiences are uncomfortable, they are actually a normal part of the adjustment process. And in fact, an important part of stroke recovery is the survivor learning to recognize and express their thoughts and feelings about stroke rather than trying to ignore them or holding them inside. So let's go through some real life examples that you might have heard from a stroke survivor. So you might have heard a survivor express shock or surprise, which was reflected in statements like, "I can't believe this is happening to me." You might sense anger when a survivor says things like, "This isn't fair. What did I do to deserve this?" When a survivor says, "No one understands what this is like," that reflects loneliness. A lot of survivors are fearful or afraid because they've had a near-death experience. Sometimes you might meet a survivor experiencing denial. They say things like, "It's fine, I'll be back to normal before you know it." Anxiety about future threats is very common after stroke. Survivors might say things like, "If I don't exercise more, I'm going to have another stroke." When there's a significant change or loss, we often see expressions of sadness, like when a survivor says, "I miss being able to play with my grandkids on the floor." You may have heard a stroke survivor say, "I should have done more to prevent my stroke from happening," which reflects guilt about past health behaviors. A lot of survivors experience shame after their stroke and say things like, "I'm useless now, I'm a burden to my family." And finally, you've probably seen expressions of embarrassment, like when a survivor says, "It's not normal to need help pulling up my pants." So as you're all very likely aware, stroke symptoms require the survivor to adjust or adapt to a new reality or way of being. And I'm sure everyone on this call is fairly familiar with common stroke symptoms, but we know that a survivor could have any combination of altered sensation, changes in voluntary motor control, perceptual deficits, pain, cognitive impairments, emotional challenges, speech difficulties, swallowing difficulties, and these symptoms often stand in the way of various domains of functioning. So there are activities of daily living, the kind of really basic things we need, like the ability to toilet, transfer, and feed ourselves and dress ourselves, stand and walk. and then also those instrumental activities of daily living, like managing finances, being able to do transportation, shopping and meal prep, house cleaning, that kind of thing. In the rehab setting where I work, the primary focus is on adjustment to functional impairments. But as a mental health provider, I'm often looking beyond that when I'm considering a survivor's adjustment to stroke. I'm focused on how stroke affects people psychosocially. So conceptually, you can think of stroke as having implications for three things. First is the survivor's identity. So that's how do they see themselves? Next is their social roles, which is how they relate to others. And finally, we have their valued activity engagement, which is how they spend their time. Now, how greatly these domains are affected might depend on the severity of the stroke or the nature of their symptoms, but I would argue even the most minor strokes change the patient's life because they lose that old version of themselves that never had a stroke. So we're going to go through each of these domains in a little bit more detail. So you can think of identity as that survivor's own perception of themselves. So how do they see themselves in terms of their usefulness or competence? What do they see as their personal strengths, their cognitive or intellectual capacity, their sense of body image, or their social desirability, or their emotional fortitude? And after a stroke, the survivor's sense of identity can be altered. And unfortunately, that's often in the negative direction. So as an example, a survivor who previously thought of themselves as very emotionally strong and stoic might find themselves being more tearful than they're used to. So sometimes this threat to pre-stroke identity can lead to some pretty negative statements about themselves. You might have heard stroke survivors refer to themselves as weak, less than, useless, stupid or dumb, ugly or undesirable, and a burden. And not everyone is going to say statements that are that extreme or that direct, but sometimes we can find this kind of lurking underneath other statements that they might make. Social roles have to do with belonging and how we relate to other people. So our survivors identify as a parent, a child, a spouse, an employee, a homeowner, or a member of a certain community. And after a stroke, there may be changes in the survivor's ability to fulfill their social roles in the way that they're used to. So an example would be a teacher who's not able to work because of their stroke symptoms normally finds a lot of meaning through nurturing children in the classroom and has experienced a loss while they're not able to fulfill that role. So we often see survivors experience a lot of upset about losing their sense of meaning or purpose, contributing to their relationships less or differently than before, feeling disconnected, and being more dependent on others than they're used to. And finally, there can be changes to their valued activities. So this might include what they consider self-care behaviors, their hobbies, how they approach their own hygiene or appearance, their household tasks, their physical activities they engage in for spiritual or cultural purposes, and then their social engagements. So an example of a change in valued activities would be a stroke survivor who previously loved to go fishing in their spare time is no longer able to do that because they're trying to do things one-handed. They don't have the balance required to get in and out of the boat. They can't drive the vehicle that's required to launch the boat. And we know that changes in valued activity engagement can be a product of a number of things. Sometimes it's reduced interest in previously enjoyed activities. Sometimes it can be those physical or cognitive deficits might be limiting their ability to participate in the way they're used to. And other times we see that it's an access issue. There's either physical accessibility barriers, there's transportation issues, or there might be financial constraints. So now it seems important to talk about a few difficult topics that often come up after stroke. So the first big one that I think of is uncertainty. So when humans feel threatened, we often look for certainty to help us feel safe. And after a stroke, it's very common for survivors to look for certainty and reassurance, especially from their healthcare providers. You'll hear them ask things like, why exactly did this happen? How long until I'm back to normal? How much functional return will I see? Will it happen again? They ask these things because most people have an implicit belief that certainty is the way to predict, prevent, or protect against future threats. The challenge, as you all likely know, is that nothing in life or in stroke recovery is completely certain. We can provide survivors with information and hope, but it is pretty much impossible to ease all of their uncertainty. So that can really be challenging. The second difficult topic I think of is lack of control. Humans like to feel that there's something we can do to prevent bad things from happening or to ease our suffering after something bad has already happened. We feel safer when things are controllable. In clinical practice, we see this search for control in a few forms. Often we see survivors reflect on past health behaviors with what I call the coulda, shoulda, woulda lens. I should have eaten healthier. If I would have taken my medication more regularly, I might not have had a stroke. I could have gone to the doctor earlier. The logic they're using when they see these things is, if I can understand why it happened before, I can prevent it from happening again, because that's a lot more comfortable than believing that there's nothing we can do to prevent bad things from happening. Other examples of this striving for control are when survivors ask providers questions like, what can I do to promote neurological recovery? How do I make my recovery go faster? Again, they're looking for concrete and controllable things, but similarly to the certainty dilemma, complete control is really not a reality. And the most unfortunate example of this is time. We know time is an important variable in neurological recovery. A lot of things tend to improve over time, but it is the most vexing variable for survivors because there's no way for them to speed it up, slow it down, go back, jump forward. They can't control it. Stroke survivors are often thrust into a situation where they have less autonomy and independence than they're used to, especially in the early stages of their recovery. Stroke deficits may make them less able to live life how they choose and often requires them to be reliant on others in a way that they're not used to. In the rehab setting, we see this loss of autonomy and independence every day when we work with survivors who require assistance from staff or from family with all of their ADLs or their IADLs. A pretty universal example of reduced autonomy and independence is the medical suspension of the survivor's driver's license. Losing the ability to take yourself where you want, when you want, is very significant for most people to adjust to. With enough time, most survivors can wrap their heads around their driver's license being suspended temporarily, but those with enduring perceptual or cognitive deficits might have to deal with the possibility of never being able to drive again, which means relying on others or on public transportation in the long term. And this is understandably a really difficult thing to wrap their head around. Perhaps the most difficult topic of all is acceptance. I spent 5 years writing a dissertation on this topic and I still haven't figured it out. What I know for sure is that acceptance is a really loaded word that means different things to different people. And how it's defined in the literature is not always how it's used in real life conversation. Clinically, we'd probably say that acceptance involves acknowledging and embracing the present moment, including its difficulties and discomforts, without judgment, resistance, or trying to change or control it. In layman's terms, the best definitions of acceptance that I've heard are, it is what it is, and let it be. The challenge is that humans do not want to accept unpleasant things if we can help it. This is why for many survivors, acceptance is considered a bad word that kind of represents to them like resignation or giving up hope. They're not ready to think about or talk about accepting their stroke symptoms and their impact on functioning, especially not in the early stages of recovery. And this can be quite a challenge for providers when you're trying to talk about prognosis or if you are trying to determine if they need to be discharged to a higher level of care. So far, we've talked about kind of normative adjustment to stroke, and now we'll delve into into the more impairing mental health challenges we see after stroke. So a subset of stroke survivors will experience clinically significant emotional lability after their stroke, meaning they're going to have a reduced ability to regulate or control their emotions. They might cry suddenly and uncontrollably. They might laugh at inappropriate times. They might experience explosive anger that's not typical for them. And this is often really troubling for the survivor, their loved ones, and their care providers. So as an example of post-stroke lability, I once encountered a survivor that would come to our sessions in a calm, regulated state, but shortly after we started talking, no matter what we were talking about, they would devolve into really intense and uncontrollable crying. Their face would go from neutral to totally crumpled in a matter of seconds, and they would often sob like loudly and uncontrollably. I always explained it to others like they suddenly fell off an emotional cliff. And they would usually recompose themselves within a few minutes, but inevitably they would fall off that cliff again shortly after, and this pattern would repeat itself in our sessions, and it happened when they were upstairs on the rehab unit as well. So it's really difficult for people to cope with. I won't go too far down the path of neuropsychology, but we know that post-stroke emotional ability occurs for some people when one or more regions of the brain that contribute to emotional processing or regulation are damaged by their stroke. I'm not going to go too deep into specific diagnoses, but there are a few clinical disorders we see more commonly after stroke. So the diagnosis of adjustment disorder might be given after someone experiences a stressful event like a stroke that results in new symptoms of anxiety or depression, but not to a level that would satisfy the diagnostic criteria for another disorder like major depressive disorder or a specific anxiety disorder. So I think of this as someone whose emotional symptoms are more excessive than we might consider normal, but not so extreme to debilitate them. It's kind of a weird in-between diagnosis. The most well-researched post-stroke mental health disorder would be major depressive disorder. We know a significant proportion of stroke survivors will experience clinically significant depressive symptoms in the years after their stroke, which is part of the reason why we know mental health screening in survivors is so important. Generalized anxiety disorder would apply to those who experience persistent and uncontrollable worry about a number of things for a period of at least 6 months. Some survivors might have suffered from generalized anxiety disorder before their stroke, and now it's worse. Others may develop it in the months after their stroke. The next category of disorder we might look for would be somatic disorders. So a degree of health anxiety is pretty normal after a major medical event. So for example, a stroke survivor will typically be concerned about having another stroke, the same way a cancer survivor might be concerned about reoccurrence. But a subset of people are going to demonstrate a preoccupation with anxiety about their health to the point where it affects their health behaviors and it affects their functioning. So for example, they might be really hypervigilant to physical symptoms in their body. They might engage in excessive medical reassurance seeking. And depending on how this manifests, we might consider diagnoses of illness anxiety disorder or somatic symptom disorder. For some, but not all survivors, experiencing a stroke is a traumatic event, and some can experience post-traumatic stress disorder after the fact. So as an example, there could be a survivor who experienced a stroke when they were at home late at night, and I'm presuming this person has recall of this event. They can remember not being able to move, not being able to call out for help. All they're capable of is incomprehensible wailing, which after a lengthy period of time gets the attention of someone else in the house who is sleeping. So months after their stroke, this patient might still be haunted by intrusive memories of being incapacitated and unable to call out for help. They might be having nightmares of a similar theme. Those would be signs that we would want to do a more in-depth assessment for post-traumatic stress disorder. And finally, we can't overlook sleep disorders. Most stroke survivors experience persistent sleep disruption, or sorry, not most, many experience persistent sleep disruption after their stroke, which could be a new thing after their stroke, or it could be an exacerbation of a pre-existing issue. For some, this might represent chronic insomnia disorder, and for others, it might be undiagnosed or untreated sleep apnea, whether that be obstructive sleep apnea or central sleep apnea. So now we'll get into part 2, which is things that every care provider can do to support psychosocial adjustment to stroke. The first opportunity comes when you're delivering stroke education to a patient and their family. I like to think of it where any provider can subtly plant seeds that help promote good adjustment to stroke. So things that I would like to be widely normalized amongst stroke survivors. I would love if every provider would label or acknowledge stroke as a change or a loss. We want to validate the stress that survivors are experiencing and the uncertain future that they're having to navigate. We might also want to acknowledge the change being faced by the survivors' loved ones, as we know that they're indirectly but still significantly affected by the stroke. We should all be normalizing emotional upset after stroke. I want you to think to yourselves, if I was in their shoes, I would very likely feel that way too. We want to emphasize that having negative reactions to stroke is not necessarily something that's abnormal or worth pathologizing. We want to acknowledge that stroke survivors are grieving their pre-stroke identity, social roles, and valued activities. We want to let them talk about their losses and at the same time instill hope that they can work to get some of these things back. In the early stages, I don't think it hurts to frame things as these losses as temporary because we really won't know for sure until some time has passed. And that usually helps them cope a little bit better. We want to validate distress that comes from this uncertainty, this lack of control, this reduced independence. We want to acknowledge that it sucks to not have certainty, to not have total control, to not be able to do what they want when they want without help. And finally, we want to express that it's quite normal to include a mental health provider as part of a stroke recovery team. Even before you know a patient will need mental health support, you can make general statements about the availability of mental health services as part of their recovery as needed. And that way, the survivor might feel slightly less self-conscious or ashamed if they ultimately do require mental health support. Things that I would love for people to promote. We want to encourage survivors to express their thoughts and feelings about stroke rather than holding them inside. And this expression could be to providers, to family, to friends. It shouldn't just be reserved for mental health professionals. And keep in mind that not everyone has a large emotional vocabulary or is used to thinking about what they're thinking. So sometimes this takes a lot of practice. Once we get a survivor expressing their thoughts and feelings, we need to make sure that we respond to that in a certain way. What I would like to promote is not relying too heavily on positive thinking, gratitude, and reassurance as an answer to expressed negativity. If every time a survivor expresses a negative thought or feeling, they're told some version of focus on the positive, it could be worse, or everything's going to be okay, sometimes that can be invalidating of their current suffering or their true experience. So I've been in situations where I would have a survivor that would say something along the lines of, this is horrible. And a family member would immediately say, but it could be worse. And while it might be accurate that it could be worse, it doesn't negate the fact that the current situation is horrible. And if we change the language a little bit in an attempt to allow that negative and that positive to coexist, we often get a better balance. So some call this replacing your buts with ands. So this is horrible and it could be worse. I'm excited to be discharged home and I'm terrified to be discharged home. I don't want to live in an accessible apartment and I need to live in an accessible apartment right now. There's very few instances when a sentence can't be improved by replacing but with and. So come back and tell me what that's like for you as you practice it. We want to encourage survivors to balance information seeking about what is known with tolerating uncertainty when it comes to things that are unknowable. And we want to normalize not having all the answers. We should be promoting a focus on what survivors can control in the moment, but also acknowledge the things that they can't control. When there are identified goals, we want to make sure that they are being approached from that SMART goal approach, which is we want them to be specific, measurable, attainable, relevant, and time-bound. This is especially relevant for secondary prevention health behaviors. So eating healthier is a really broad and vague goal. It can be really intimidating for a lot of people. We want to encourage survivors to break it down into smaller chunks. We want to say start small and build up, and that any change is better than no change. This is what helps people get started. It's particularly important to encourage survivors to reflect on what they consider success or progress during their recovery or during their rehab. Their normal urge is to compare to their pre-stroke self or to others who aren't in their shoes, which is really a top-down approach. This is an unfair comparison because if the metric of success is getting back to my old self, anything less than that is going to feel like a failure, and that can be crushing. We want to encourage a more bottom-up approach where they celebrate even the smallest victories or improvements, and we want to promote comparison to the way they were right after their stroke at the worst. One of the trickiest things to promote is balancing hope for change or improvement with accepting things how they currently are. We need survivors to understand it isn't an either or. An example of this would be a stroke survivor accepting their need to use a wheelchair in the here and now, at the same time holding on to hope that there might be a day where they no longer need to use a wheelchair. We can't force acceptance. We can't say magic words and flick the acceptance light switch. It is kind of something that occurs with time and experiential learning for a lot of our survivors. And finally, we want to promote self-compassion as an alternative to self-criticism. We want survivors to understand that being hard on themselves is not what is going to get them through this. In fact, it's probably going to weigh them down. We want them to recognize that those self-critical statements when they occur and try to practice reframing that in a compassionate way. So, how can I be nicer to myself? How can I cut myself some slack? What would I say to someone I love if they were in my position? Because I probably wouldn't talk to them the way I'm talking to myself. The second opportunity for every care provider to make a difference is to always be looking for signs that the survivor might require additional mental health support. So in other words, you can be looking for red flags that might indicate a formal mental health referral is required. So what are these red flags you should be looking for? Broadly, I think the first red flag would be signs of intense and persistent emotional distress that affects functioning. So this can look a few different ways. One thing we might look for would be intense and persistent low mood. So people who are down, sad, hopeless, blue, or empty a lot of the time. We might want to look for signs of uncontrollable worry. So those people who are drowning in what ifs, they're spinning or spiraling on the same topics. They might ask the same question repeatedly, and that's not because they have a cognitive issue that makes them ask the same question repeatedly. It's more of a digging and trying to get to that answer that reassures them. We might want to look for catastrophic statements. People are making a lot of worst case predictions about future threats. We might look for excessive negativity or pessimism. So some people, you can get a sense that they are really seeing the world through a dark lens. Certain behavioral outbursts might be signs that mental health support is required. So if we have someone who is just really chronically irritable or who is having a lot of temper outbursts. And finally, we might look for challenges with anhedonia or avoidance. So people who are isolating, withdrawing, avoiding certain things, that may be an indicator that more support is required. Other red flags you might look for, statements reflective of hopelessness, despair, death, suicide, or non-suicidal self-injury. So people are saying, I can't do this anymore, life is not worth living, I'd be better off dead, I don't want to live like this, thinking about killing myself. A popular one, or I shouldn't say popular, but one we've heard is, I want to cut off my hemiplegic arm. What's the phone number for MAID? Those types of things. They aren't necessarily, if someone says that one time, we're not necessarily sending up a red alert, but especially if you're hearing those messages repeatedly, we probably want to have a more in-depth assessment of what's going on there. Intrusive symptoms related to stroke that might lead you to wonder if this person has post-traumatic stress disorder. So if someone is telling you that they're having a lot of intrusive memories about their stroke, they're having nightmares, flashbacks, or there's a lot of distress when something reminds them about the stroke, this can kind of be a tricky one. And I bring up these re-experiencing symptoms specifically because they are unique to PTSD. There are other symptoms that are required to make PTSD diagnosis, but they tend to overlap with other disorders, so it's a more complicated differential. We might want to look for hyperarousal symptoms. Is that body alarm system on high alert? And the best example of that would be, is this person having panic attacks that are really distressing, uncomfortable, and impairing to them? We want to look for signs of persistent sleep disturbance. So if we're talking insomnia, we want to be looking for those insomnia symptoms at least 3 nights a week for a number of months. Or we might want to flag people who are non-adherent to their PAP therapy when obstructive sleep apnea has been diagnosed. We really want to see if we can get some assessment or intervention to help them on their way with that. And finally, if you notice behaviors that are getting in the way of rehabilitation, so if the survivor's having angry outbursts at staff or family, or they're not attending therapies, they're withdrawing, we probably want to get a sense of why that is, especially if there's kind of a mental health reason for that. The final opportunity for every care provider to make a difference is to actually make a mental health referral if you think your patient is not adjusting well post-stroke. The referral really allows a qualified mental health provider to do a thorough assessment, which in turn can inform any mental health intervention. Once you make a referral, an assessment is going to occur, and what that assessment entails might depend on which provider is doing it or the setting, different things. But here's what I generally think of as the components of an assessment. So obviously we're doing data collection. We're digging deeper into what's going on from a biopsychosocial perspective, and we can do that from reviewing file information, the electronic medical record. We can have a clinical interview with the survivor or their loved ones. We could perhaps give them some questionnaires to complete. Of course, there's a big if the survivor is cognitively appropriate for self-report measures with that one. But we really want to get an understanding of that survivor before their stroke. So their pre-morbid mental health, their social network, their values, as well as their current mental health symptoms and the impact of those mental health symptoms on their functioning. After we collect all that data, psychologists especially love to do case conceptualization, where we're basically taking the information we gathered from those multiple sources and weaving it into a coherent story or conceptualization of what's going on for that survivor. So we often talk about the 5 Ps of cognitive behavioral case conceptualization. So we want to get a sense of what are the presenting problems. Is there just one or is there many? When did it start? How often is this happening? We want to know about predisposing factors, so things that make them vulnerable to poor adjustment at this point in time. Is it past mental health problems? Is it chronic social stressors? Is it social isolation? We want to know about precipitating factors, which is things that might have triggered this current mental health challenge. So is the stroke the big thing that happened, or are there other things that triggered a mental health deterioration? We especially want to look for perpetuating factors or things that might be keeping this mental health challenge going. So that could be withdrawal, it could be avoidance, it could be that negative cognitive bias that really keeps that ball rolling. And finally, we want to look at protective factors. So things that actually are strengths that might protect this person as they go through their adjustment. So do they have good social support? Are they pretty high on that psychological flexibility spectrum? Do they have economic resources that others might not? We may or may not make a mental health diagnosis depending on the case. Sometimes our current categorization of mental health disorders has its limitations, but it can be helpful in directing us towards certain treatments. And finally, of course, we're going to make treatment recommendations based on that case conceptualization. So we might recommend specific interventions. We might recommend additional referrals. We also might speak to the prioritization of treatment targets if there's many. So a thing my team has heard me say a lot is it doesn't make sense to reorganize the basement when the house is on fire. And I say that especially about our inpatients where their whole life is in upheaval from the stroke. They're not living at home. They can't walk. They can't go to the bathroom themselves. So, for example, if we have a reason to think maybe they had ADHD before all of this, that's not unimportant. But while the house is on fire, trying to get them signed up to do a comprehensive ADHD assessment maybe doesn't make sense. So we're just trying to prioritize those treatment targets because often there are many. When it comes to mental health intervention after stroke, we're generally talking about 3 things. First would be talk therapy. We can consider medication, or we can consider peer support. So when it comes to talk therapy, I'm biased because that's what I do for a living, but I think talk therapy should be that first-line treatment for any survivor who's having difficulty adjusting to stroke. In talk therapy, we rely heavily on the therapeutic relationship as a key factor in successful talk therapy outcomes. We know that having that professional, trusting, and collaborative bond between that survivor and a provider that's built on empathy and respect and boundaries, that's what creates a safe space for them to explore their thoughts and feelings, gain insights, and achieve growth and healing. And then on top of that therapeutic relationship, we might choose to deliver a specific intervention. So if a specific clinical mental health issue is identified, an appropriate evidence-based psychotherapy is likely chosen. So you've probably heard of some of these before. If we believe someone is suffering from major depressive disorder, we might do a specific cognitive behavioral therapy protocol. If someone has post-traumatic stress disorder, we might use prolonged exposure therapy or cognitive processing therapy. If someone has panic disorder, we might do interoceptive exposure. If someone has chronic insomnia disorder, we might do cognitive behavioral therapy for insomnia, which again is a very kind of specific form of CBT for that condition. Other times we might be looking more at delivering transdiagnostic education and skills. So it's not always about specific mental health diagnosis, but more about general education and skills to support coping. So we could talk about stress tolerance skills, we could do some grief work, we could cultivate a mindfulness practice, we might review frustration management strategies, or engage in self-compassion practice. Medication can be valuable in some cases as a standalone or ideally in combination with talk therapy. Now, which medications are recommended by a prescriber is likely going to depend on which symptoms are being targeted. And that prescriber is probably going to consider possible side effects, especially because stroke survivors are likely going to be on various other medications that could interact or compound side effects. And a common one we might be trying to minimize would be like those sedation effects on various medications. Sometimes we want to consider the survivor's pill burden. So kind of what's the cost benefit trade-off of prescribing yet another medication for this person? But those decisions are really left to the prescribers. When it comes to peer support, we know that sometimes other stroke survivors can provide a level of support to provide a better level of support than what those of us who haven't experienced a stroke can. So if we're considering peer support, we always want to think about, is an individual format or a group format better for this person? Are we looking at a structured peer support option or unstructured, meaning is it professionally facilitated or not? Generally, the literature suggests structured is more effective, but that doesn't mean that unstructured peer support is bad or ineffective in its own way. And then now there's a lot of in-person or virtual options for peer support. And here in our province, we have the Acquired Brain Injury Outreach Programming offers some peer support options. There's March of Dimes, and I'm sure there's others as well. If possible, it's helpful to preemptively identify barriers to the survivor's participation in various forms of intervention. So if they've had a past negative experience in therapy or counseling, more work might need to be done to convince them that that's worth trying again. People sometimes have a lot of apprehension about taking medication for their mental health. You might need to provide education to work through their concerns about stigma, side effects, becoming addicted, the cost of those medications. And we always want to consider if there are limitations in the survivor's ability to participate in certain types of intervention. So can they communicate well enough to participate in talk therapy? Can they routinely attend therapy sessions? Can they maintain medication adherence? Can they tolerate a group peer support setting? I'm just going to skip over one slide because I'm aware of the time and I want to make sure to save time for questions. So when we're making a mental health referral, there's a few things that I would recommend you take into consideration. One is, what is the reason for referral? So ideally, we would love for everyone to include a description of what you're seeing in that survivor's presentation that concerns you. What are those red flags you noticed? And always, if there's a specific question that you would like answered, that's always helpful to include in the referral. And you can consider, am I referring for an assessment, intervention, consultation, or am I going to leave it at the discretion of whoever I'm referring to? We want to consider who you're referring to. So in ideal circumstances, we would love for every survivor to have access to a mental health provider with expertise in stroke. If that's available in your option, that is great. The unfortunate reality of mental health care, though, is that specialized providers are not always available where and when we need them. In this case, the reality is that any mental health provider is better than no mental health provider for stroke survivors. We also want to consider who is doing the referral. So consider whether you'll be making the referral as the provider or whether there's a self-referral option that's available or appropriate. But oftentimes survivors are still going to need help navigating or narrowing down which service is best for them. So there's a lot of things that you might consider when trying to choose the right mental health service. So first of all, financial resources. What can the survivor afford? Do we need to look at public or free options? Nonprofits, which tend to be lower cost. Is there a third-party payer involved, or is this going to be personally funded out of pocket? We might need to consider the discipline that we're referring to. What kind of provider does this survivor need? When it comes to talk therapy, is there a specific need for a clinical psychologist, or could they see a counseling psychologist or a social worker? When it comes to medication, can the family physician manage the assessment and prescribing, or is a psychiatrist required? We want to look at urgency, which is how long can the survivor afford to wait to access mental health services? The public services typically try to do triage quite quickly, but then there can be a wait for actual services. Some nonprofit options offer quick access, but that typically is time-limited intervention. And private mental health services is really a toss-up, usually depends on the provider or the practice in terms of how long that wait is. And then we also want to look at accessibility. Can the survivor actually participate? So if in-person services are being pursued, we want to consider what the physical barriers to access might be in terms of stairs, doorways, bathrooms, seating options, as well as likely transportation challenges. And if virtual services might be an option, we have to consider the survivor's technological literacy, whether they have an appropriate device to participate with, and whether they have a private space to participate in virtual therapy. And then finally, we have those kind of unique characteristics of survivors that might need to be taken into consideration. So does this survivor need a clinician who works within specific cultural or language parameters, that kind of thing. Now, I added this slide at the last minute because I knew inevitably people would be asking about like specific places that they can refer survivors. I was so nervous to like put this out there because I don't want to send people on a goose chase, but I figure giving you something is better than nothing. So on this slide, I just have free or low cost options for mental health support on an outpatient basis. So I kind of grouped them. First, I put the like general mental health services, which is in that category of any provider is better than no provider. So these would all be self-referral options that the survivor or their family could do. So there's always going to be a community mental health clinic in your area. There's going to be different phone numbers to call depending on your geographical area, but that information can be found on the SHA website. There's Counseling Connect Saskatchewan, which does rapid access counseling. I think that one's through Family Services Saskatchewan. Most people are well aware of the University of Regina Online Therapy Unit. They have a number of different programs for well-being, insomnia, chronic health conditions. There might be some limitations with that option when it comes to stroke survivors because it does require a level of self-direction and logging in and going through that material, but I don't think we should rule it out by any means. And then there are the psychology training clinics at the U of R and the U of S. That would be PhD psychology students delivering services under the supervision of a registered psychologist. A lot of times they are offering different groups, different services for either a no cost or a reduced cost. We do have a few kind of specialty mental health services as it pertains to health and rehab. So this would be ideal for all of our stroke survivors to be able to be referred to these services. But right now I'm pretty confident that there's unreasonable wait times for these two services for a lot of people. So here in Regina, it's the program I work for, the Adult Therapies program. In Saskatoon, for outpatients, it would be the clinical health psychology program. And then just one quick spot here on the specialists. Among specialists would be neuropsych assessments. There is the general neuropsychology service in Saskatoon out of RUH. That requires neurology, neurosurgery, or physiatry referral, from what I understand. And there are specific eligibility requirements of what types of things they assess. And I do not know the current wait times for that service. So I would love to have saved more time for questions, but I am going to open up all my windows here. And I put my email there in case anyone has questions after the fact.
Oh man, thank you, Kirsten. There are so many, like, so much info and some really nice pearls that like we can take away from your presentation. And people are wondering, there's some questions in the chat. Number one, can we share your presentation? Would that be okay?
Yes.
Okay, so that'll come out in the Coffee and Cases newsletter, you guys. Number two, some questions around mental health screening and people with aphasia. Is there any tools that you would recommend, or is there any talk therapy people who specialize in those with aphasia? If you don't know right now, that's okay. If you do know something off the top of your head, that's okay. If not, we will also kind of take
It's a great question.
Great question. Very good question.
Yeah,
But
I do not have the answer off the top of my head. I do not. I told my colleagues that like they could help me answer questions if there was something I couldn't, so I don't want to put any of them too much on the spot. But
Yeah, I can help a little with this. So I mean, for people who don't have aphasia, like the PHQ-9 and GAD-7 are good measures to use, and they're widely used. The SAD Q21 is a measure specifically for folks with aphasia, and it's usually completed by a caregiver who knows the patient very well and has been present throughout their hospital stay. Or if a caregiver is not available, like a member of the nursing team, but again, a person who's been working with the patient over a period of time. So that's a good measure. I can probably put the link in the chat. Oh, I should maybe introduce myself. My name's Rachel. I'm Kristen's counterpart in Saskatoon at the rehab center at City Hospital. I'm also a psychologist.
Oh, thanks, Rachel. And whatever you send us, we will include in the monthly newsletter. So if people don't get it at this second, it is coming to your inbox. We'll include the presentation, Kristen's email, any kind of links in terms of resources that you guys are sending us. This is great.
Yeah. And the other question was about psychologists or clinicians who are familiar in offering talk therapy to folks with aphasia who are really, of course, obviously struggling with their speech. So I'm extremely fortunate because I work with speech therapists here. So I've been able to learn the supported communication for aphasia strategies, but I really think the best thing is actually co-treatment with a mental health provider and a speech therapist together. I appreciate that that's quite specialized and not widely available. I think the other thing that's helpful is if a patient is working with an SLP, for that SLP to provide some recommendations to the mental health provider and some of the links. And I do think in general, if more folks were aware of some of the supported communication strategies, that would be helpful for all of us. But I'd say try to make friends with your local SLPs if you are a mental health provider who works with folks who have had a stroke. Yeah.
And talking about supported communication, there's a nice little course through the Aphasia Institute that is very beneficial, and it's accessible to anyone. So we can put that link in as well if you're looking for ways to communicate better. We are going to have a month on SLP either in April or May, so that more specifically will be coming. And then I just want to know, again, shout out to Heart and Stroke for the Your Stroke Journeys. I don't know if you guys can see that. No. Anyway, it's your.
Hold on, I got one here on my desk that won't get
Okay,
blacked
Your
out.
Stroke
Oh,
Journey.
where did mine
Please.
go? There we go.
Please use this document. And if you're not using it, order it. They're free through Heart and Stroke. And there's a whole chapter for your patients and their families, all on living with changes to emotions, energy, and cognition. And it kind of goes over some of the high points that were covered about feelings that you might experience, controlling emotions, talking about depression, signs of depression, what you should do, what's the difference between being sad and being depressed. So a really, really excellent resource.
I was just looking too, there is a chapter in the stroke rehab clinician handbook about depression and community reintegration. So I know I looked at the Your Stroke Journey and that stroke rehab clinician handbook as a provider if I was looking for a little bit of information about that.
Okay.
You have time to do a couple shout outs?
Yeah, let's do a couple shout outs here for Rewire and Inspire, our new feature at Coffee and Cases. This is just a starting spot, so we're expecting a lot. I see you, Battleford. I see you, Regina. I see you, everybody else, Rec Therapy. Shout out, please send us shout outs for your coworkers around the province. Ashley.
Okay, so there was a shout out for Saskatoon who just got their stroke accreditation. And then there is a shout out for the psychosocial team at City Rehab. Someone that works with you really appreciates the strong and cohesive team that you have there and the ability to support patients' mental and social well-being. So thank you. That includes psychologist, social worker, and rec therapy. And then there's a shout out here for the STARS crew. Melford.
From the STARS crew.
From the STARS crew. Melford did a very good job getting the TNK into a patient quickly and then packing them up and transferring them to Saskatoon.
Yeah, STARS had all the good things. I don't know, is there anyone from Melford on here? Stars had just raved about you guys in these, I won't tell you when, but in the last few weeks, when a patient came in, they were like so impressed with the care you gave. So amazing, so much good stuff happening around the province. Do you want to say something else, Ashley?
I'm gonna say one more thing, one
Okay.
more shout out from this is my own shout out. I'm doing a shout out to my neighbor Kelly, who's on this call. She sent me a nice little email today because she must have been able to tell how frustrated I was with WebEx again. So she sent me an email telling me that I'm doing a good job. So I really appreciate that, Kelly.
Yes, producer Ashley.
We're just gonna do single links from now on. No more of this series with IT. No.
Yeah, it's not Ashley.
Thank you,
It's,
Ashley.
as you guys are aware of SHA, everything is complicated and nothing runs smoothly.
They're like, just make another one. I'm like, no. So you can delete all of the series in your calendars.
Brett, any shout outs?
Oh, so many shout outs.
Putting Brett on the spot.
So many shout outs as I'm dissociating elsewhere. No, I'm not. I'm not. Again, big shout out to producer Ashley. Just because she's a decade younger than we are.
Yes.
So we're not very technologically skilled, savvy,
Yes.
skilled. So it makes this
Neither
feel
am I.
like a real program. So
Yeah, thanks. Thank you, Ashley. And next week,
month.
next month, I mean, for Coffee and Cases, our recreational therapists are going to share. What is the topic?
Don't have it
We
here.
cannot wait
It is
because it's Rec Therapy Month.
Beyond Survival, Connecting Through Rec Therapy.
Okay, so there's going to be some rec therapy, and then there is going to be a surprise presenter coming soon. We will let you know. Okay, people are logging off. It's 4:01. Time to go.
we salute
Salute.
to our speaker.
Yes.
Kristen, thank you for
Kristen,
sharing your
amazing
time.
job. Thank you to all our psychologists around the
The
province.
great work you guys
You
do.
do big things with very few humans, and so we appreciate you.
Thank
This
you.
will be on our YouTube channel.
And this will be on the YouTube channel if you want to rewatch it.
Yep.
So give us a
Okay.
like, subscribe, all those things.
Share, blah blah.
We might get some money from this. No, we
No, we won't. Okay. Okay, thank you guys. See you next month.